So picture this. You open your eyes, and it's maybe 6 in the morning.
Right?
The alarm hasn't even gone off yet. And before you can even register the sunlight coming through the blinds, you just feel it.
Oh, yeah, that feeling.
Yeah, that dull, rhythmic pounding right behind your eyes. Or maybe it's like a tight, suffocating vice gripping your jaw and your temples.
It's just the worst way to start a day.
It really is. I mean,
Yeah.
you haven't even started your day, right? You haven't looked at a screen. You haven't dealt with a stressful commute. And already, you're in a physiological deficit. You're
Yeah.
waking up in pain.
Which is incredibly frustrating for so many people.
Exactly. And normally, when we talk about a medical diagnosis, there's this expectation of precision. Like if you fall and break your arm, the X-ray shows a jagged white line on a black background, right?
Right. The doctor points to it, and the reality is undeniable. It's totally binary, broken or intact.
Exactly. Broken or intact.
Mm-hmm.
But when you step into the world of every day, chronic symptoms specifically, waking up with a morning headache, that pristine diagnostic machinery just completely falls apart.
Because you can't exactly X-ray a morning headache.
You really can't.
Yeah.
We're looking at a diagnostic landscape that is just incredibly murky, where the pain is very real, but the culprit is hiding in the shadows of your own biology.
And your daily routines, yeah. Because a morning headache is basically a symptom masquerading as a condition.
Oh, I like how you put that. Masquerading as a condition.
Yeah, I mean, it is rarely the main event. Instead, it's the trailing exhaust of a highly complex biological process that has been playing out in your body for the past 8 hours.
So waking up in pain is really your body's way of sounding an alarm.
Exactly. It's sounding an alarm about a web of unseen factors. And these factors are heavily influenced by, well, the medications you take, the way your liver processes chemicals, the architecture of your sleep, and even the shifting tides of your circadian rhythms.
That is just wild to think about. And you know, when you look at the massive amounts of data synthesized by independent medical information platforms, and specifically for our deep dive today, we are looking at insights drawn from the iMedix report on medication safety. A really fascinating narrative emerges.
It really does, and it's a narrative that patients desperately need to hear.
Right, because this isn't just about figuring out if you slept on a bad pillow. This is our mission for today. We are exploring the intersection of a universally frustrating issue and how it intrinsically ties into medication, safety, patient education, and the absolute critical need for reliable information.
We really have to look at the underlying mechanisms to understand why our bodies are betraying us the literal moment we wake up.
Right. So to truly understand those mechanisms, I guess we need to pull back the curtain on the nighttime body.
We do, because, we tend to think of sleep as an off switch. You power down at 11, and you power back up at 7.
Like a smartphone.
Exactly like a phone. But biologically, the night is a period of intense orchestrated labor. Your liver is furiously metabolizing toxins and medications.
Wow. So it's working overtime while we're unconscious.
Oh, absolutely. And your brain is cycling through distinct architectural stages of sleep, flushing out metabolic waste through what we call the glymphatic system.
The glymphatic system, I've heard of that. Like taking out the cellular trash.
That's a perfect analogy. Your hormones are surging and dropping, your blood pressure is undergoing vital dips. And when you introduce a foreign variable into that symphony, whether it's an over-the-counter painkiller, a prescription antidepressant, or even just a glass of wine, you run the risk of knocking the entire orchestra out of tune.
Okay, let's unpack this. Because trying to understand medication risks and how they disrupt that nighttime orchestra without a dedicated independent platform is like trying to navigate a dense jungle using a map drawn by a toddler.
I love that comparison. It's so true.
Right. Like you might recognize a tree here or a river there, but you're definitely going to get profoundly lost. You take a pill to fix one problem, and you wake up with a totally different one, completely oblivious to the connection.
Which happens every single day to millions of people.
So why is this specific risk, the risk of the morning headache, so universally misunderstood by the average patient?
Well, if we connect this to the bigger picture, the misunderstanding stems from a systemic lack of accessible translation. The data exists,
The clinical data, you mean?
Yeah. When a pharmaceutical company runs a clinical trial, they produce mountains of data on adverse events. But without platforms whose sole dedication is translating that data for patient education, the vital context remains locked behind dense medical jargon.
It's just buried in that microscopic, tightly folded paper that comes inside the pill bottle.
Yes, the package insert.
Right, the insert that feels like it requires a magnifying glass and a law degree to decipher. I mean, who actually reads that thing?
Very few people. And even if they do, it's written by regulatory lawyers for clinicians, not by educators for patients.
That makes so much sense.
If a label simply says incidence of headache, 4%, that tells you absolutely nothing about the lived experience of that side effect.
Right, it doesn't tell you when the headache's going to hit you.
Exactly. It doesn't tell you when it occurs, the physiological mechanism of why it occurs, or how it might interact with your morning routine. And this is why an independent medical database is so crucial.
Because it does more than just list the side effects.
Right. It doesn't just list pills and chemical structures. It acts as a relational map. It tracks the causality between a drug's half-life, its interaction with your neurochemistry, and how you physically feel when your alarm goes off.
It connects the dots that the pharmaceutical label just leaves completely blank.
Precisely.
Well, that concept of causality is exactly what we need to dive into next. Let's get into the actual physical mechanics of why our heads are pounding. And I want to start with one that sounds completely counterintuitive, almost like a biological cruel joke.
I think I know where you're going with this.
Medication overuse headache. I mean, the idea that taking pain relievers to stop a headache can actually be the exact mechanism causing you to wake up with one.
It really is one of the most common yet least understood phenomena in neurology. It's often referred to as a rebound headache.
A rebound headache. Okay, so how does that actually work?
To understand it, we have to look at neuroplasticity, which is basically the brain's ability to adapt to its environment. Let's walk through a really common scenario.
Sure, lay it out for me.
Say you suffer from occasional tension headaches or perhaps episodic migraines. You do what literally anyone would do. You reach for an over-the-counter medication like ibuprofen or acetaminophen or maybe a prescription triptan.
Right, you feel pain, you treat the pain. It's the logical human response.
Exactly. But if you begin taking these medications too frequently specifically, more than 10 to 15 days out of a month, your brain registers this constant influx of pain-suppressing chemicals.
And the brain doesn't like that.
Well, the brain loves homeostasis, a state of balance. If it senses that pain pathways are being artificially suppressed every single day, it adapts by upregulating your pain receptors.
Upregulating, meaning it makes them more sensitive.
Yes, exactly. It essentially makes them more sensitive, requiring more of the painkiller to achieve the exact same effect.
So your brain is actually fighting the medication by turning up the volume on the pain signals.
Yes, that is a fantastic way to put it. Now, factor in the nighttime metabolization process we talked about earlier.
Okay, so I take a painkiller in the afternoon, and then I go to sleep.
Right. And while you were sleeping, your liver is diligently clearing that medication out of your bloodstream. As the drug's concentration drops during the early morning hours, you enter a state of mini withdrawal.
Because my pain receptors are now hypersensitive.
Exactly. Because they are hypersensitive, the absence of the drug triggers those pathways to flare up with an absolute vengeance.
Oh, wow. And so you wake up in sheer agony,
Mm-hmm.
which means the very first thing you do is reach for the pill bottle on your nightstand to treat the morning headache,
Right.
completely unaware that you were just reloading the gun for the next morning.
You reinforce the cycle.
Yeah.
The medication intended to relieve your suffering has fundamentally altered your neurochemistry to become the primary driver of your morning misery.
That is just wild. And I bet the patient naturally assumes their underlying headache condition is just getting worse.
Right. Oh, almost always. They think their migraines are progressing when in reality it's an iatrogenic issue.
Iatrogenic, meaning it's caused by the medical treatment itself.
Precisely. And breaking that cycle requires stopping the medication, which usually means the headaches get significantly worse for a few weeks before the brain's receptors recalibrate to normal.
That illustrates perfectly why understanding the why is so crucial. If you don't know about receptor upregulation, you just think you have a terrible, worsening disease.
It's all about having the right education so you don't panic unnecessarily.
Let's move to another incredibly common withdrawal mechanism, one that involves a substance most of us consume literally every day, caffeine.
Ah, yes, the morning cup of coffee.
People joke all the time, don't talk to me before my coffee, get a headache. But there's intense vascular physics happening inside the skull there, isn't there?
There is immense vascular activity at play, yes. Caffeine is a central nervous system stimulant, but its primary mechanism of action involves blocking a specific neurotransmitter in the brain called adenosine.
Adenosine, what does that do normally?
Well, adenosine is a really fascinating chemical. It builds up in your brain throughout the day, and its primary job is to promote sleepiness and to relax blood vessels.
So adenosine is kind of like the body's natural dimmer switch. The longer you're awake, the more adenosine builds up, and the dimmer the lights get.
That is spot on. But when you drink coffee, the caffeine molecules, which structurally look very similar to adenosine, rush in and bind to those adenosine
Oh,
receptors.
so they steal the parking spots.
Exactly. They occupy the seats, so to speak, preventing the actual adenosine from sitting down and doing its job of making you tired. And because of this, you feel alert.
Right, because the dimmer switch is jammed.
Right. But just like with the painkillers we just discussed, your brain notices this blockade. It says, hey, I'm not receiving my sleep signals. So to compensate, the brain manufactures even more adenosine receptors.
Is adding more chairs to the room because the caffeine is hogging all the existing ones.
That's a great visual. Yes. Now think about what happens when you go to bed.
Well, you sleep for what, 7 or 8 hours, hopefully?
Right. And for most people, sleep is the longest continuous stretch in a 24-hour cycle where they do not consume caffeine.
So the body starts clearing it out.
Over those 7 or 8 hours, your liver metabolizes the caffeine you drank earlier in the day. The caffeine unbinds from the receptors and is cleared out. Suddenly, you have a massive abundance of unblocked adenosine receptors.
And the adenosine just rushes in all at once.
It floods the system.
And what happens to the physical structure of the brain when all that adenosine hits those new receptors at 5 in the morning?
Well, remember how we said adenosine relaxes blood vessels? It's a potent vasodilator. It causes blood vessels to dramatically widen and expand.
And I imagine expanding blood vessels inside a hard skull is not a comfortable feeling.
Not at all. When the blood vessels in your brain rapidly expand, they stretch the highly sensitive nerve endings embedded in the vessel walls.
Ouch.
Yeah, this sudden, massive stretching of the vascular tissue results in a deep, throbbing morning headache. It is a textbook withdrawal symptom driven entirely by overnight metabolic clearance.
And to tie this back to medication safety, which is our whole mission today, aren't there a lot of pain meds that actually have caffeine in them?
Yes. Many over-the-counter headache medicines actually contain caffeine as an active ingredient to help speed up absorption.
Oh, wow. So a patient could be experiencing a medication overuse headache from the painkiller and a caffeine withdrawal headache simultaneously from the exact same pill.
And they both strike right when the alarm goes off.
It creates an incredibly complex overlapping matrix of pain.
It really does. And it's nearly impossible for a patient to decipher that without targeted, independent educational resources. They just think, I need more pain meds or I need more coffee.
Let's follow that thread of oxygen and blood vessels for a minute. If the expansion of blood vessels causes so much pain, what happens when the body is actively deprived of oxygen during the night?
You're talking about sleep apnea, I assume?
Yes, sleep apnea.
Yeah.
You usually hear about it in the context of loud snoring or daytime fatigue. But how does the physical obstruction of the airway actually translate into a morning headache?
Obstructive sleep apnea is fundamentally a mechanical failure of the airway. During sleep, the muscles in the back of your throat naturally relax.
Which is normal, right? For everyone.
It's normal, but in someone with sleep apnea, these muscles relax way too much, causing the soft tissue to collapse and narrow or completely close the airway.
So they literally stop breathing.
The person literally stops breathing for 10, 20, sometimes 30 seconds or more repeatedly throughout the night.
Which, just on a purely survival level, sounds terrifying for the body to endure.
It is a profound physiological stressor. When you stop breathing, 2 dramatic shifts occur in your blood chemistry. First, your oxygen levels plummet, which is a state known as hypoxia.
Okay, hypoxia. And what's the second shift?
Second, because you aren't exhaling, carbon dioxide builds up in your bloodstream, a state known as hypercapnia. And a carbon dioxide, much like the adenosine we just discussed, is a very powerful vasodilator.
Let me get this straight. So the brain realizes it's suffocating.
Yeah.
And it forces the blood vessels to expand as wide as possible to try and capture whatever tiny amount of oxygen is left in the blood.
That is exactly the survival mechanism. The brain prioritizes its own oxygenation above all else, but that aggressive expansion of the cerebral blood vessels stretches the surrounding meninges.
The meninges, those are the membranes that envelop the brain, right?
Yes, and stretching them results in a very distinct type of morning headache. It's usually described by patients as a dull, generalized, pressing pain that encompasses the whole head rather than a sharp, localized pain.
So it feels different from a migraine or a tension headache.
Very different. And the hallmark of an apnea-induced headache is that it typically fades within an hour or two after waking up.
Why does it fade so quickly?
Once the person wakes up and starts breathing normally, they blow off the excess carbon dioxide, and the blood vessels constrict back to their normal size.
That makes total sense. Now, where do medications enter this specific picture? Because I imagine if someone is waking up exhausted because they stop breathing 50 times a night, they probably go to their doctor and say, I have terrible insomnia.
And that is exactly where a potentially catastrophic medical misunderstanding occurs.
Oh no. So the doctor treats the insomnia, not the breathing.
Right. If the sleep apnea is undiagnosed, a physician hearing a complaint of poor sleep might prescribe a sedative, a hypnotic sleep aid, or perhaps a muscle relaxant.
Wait, I'm deducing that a muscle relaxant is the absolute last thing you want to give a throat that is already collapsing because the muscles are too relaxed.
You've hit the nail on the head. These medications exacerbate the core mechanical flaw. They further relax the pharyngeal muscles, making the airway collapse more frequent and more severe.
That is so dangerous.
It gets worse. Sedatives depress the central nervous system's respiratory drive. Normally, when oxygen drops, the brain sends a panic signal to wake you up just enough to gasp for air.
But the sedative blocks that panic signal.
A sedative blunts that panic signal significantly. The brain is slower to realize it's suffocating, and the periods of apnea become dangerously long.
So the medication prescribed to help them rest is actively worsening the oxygen deprivation, increasing the carbon dioxide buildup, and virtually guaranteeing a massive throbbing headache the next morning.
The morning headache in this scenario is a blaring alarm bell. It is your body desperately signaling that a dangerous interaction is occurring between a prescribed treatment and an underlying undiagnosed physiological condition.
This highlights perfectly why a generic warning label that just says may cause drowsiness is catastrophically insufficient. A patient needs to understand the structural and respiratory impact of that drug on their airway.
Absolutely. The lack of context can literally be fatal in severe cases.
Let's shift gears slightly. So if a sedative essentially paralyzes an already struggling airway, the body is fighting just to survive the night. Does that nocturnal fight or flight response manifest in other physical ways?
Oh, definitely.
Because I imagine if your brain is panicking for air or just generally stressed, the rest of your muscles aren't exactly resting peacefully.
They certainly aren't. That nocturnal stress response often travels right up the neck and into the jaw, manifesting as sleep bruxism.
Bruxism, that's the involuntary clenching or grinding of teeth during sleep, right?
Yes. And the masseter muscles, which are the primary muscles of the jaw, are incredibly powerful. When they contract involuntarily for hours on end, they put immense, sustained pressure on the temporomandibular joint, or TMJ.
I've had friends with TMJ issues, and they say it's awful.
It is. This constant muscular tension radiates up into the temporalis muscles on the sides of the head.
Which creates a very specific geographic headache, right? Like a tightness on the sides of the head and jaw.
Exactly. It's usually an aching pain, bilateral meaning on both sides, and it's often accompanied by jaw stiffness, difficulty opening the mouth fully in the morning, or unexplained tooth sensitivity.
Now, people generally attribute teeth grinding purely to psychological stress. Like, oh, I had a terrible week at work, so I ground my teeth.
That's the common assumption, yes. But the independent data from the iMedix report reveals a massive, under-recognized pharmacological link.
A pharmacological link to grinding your teeth.
Yes, particularly regarding a class of antidepressants known as SSRIs, selective serotonin reuptake inhibitors.
Wait, I'm struggling to wrap my head around this. If I take a pill designed specifically to calm my brain down, an anti-anxiety med or antidepressant, how is it chemically forcing my jaw to clench with hundreds of pounds of pressure while I'm unconscious?
It feels like a massive biological contradiction, doesn't it?
It really does. How does that even happen?
It does seem paradoxical, but it comes down to the delicate balance of neurotransmitters in the brain's motor pathways. SSRIs work by increasing the availability of serotonin, which helps regulate mood.
Okay, so more serotonin equals better mood.
Right. However, the neurochemical systems in the brain are deeply intertwined. By artificially elevating serotonin, these drugs can inadvertently alter the balance of dopamine in the basal ganglia.
The basal ganglia, what does that part of the brain do?
That's the region of the brain that controls involuntary movement.
So fixing the mood chemical accidentally disrupts the movement chemical.
Precisely. This neurochemical shift can trigger spontaneous rhythmic contractions of the jaw muscles during the lighter stages of sleep. So a patient might start taking an SSRI, feel their anxiety lifting during the day, maybe even sleep a bit more soundly. but wake up with terrible jaw-related headaches.
Because the label simply lists headache as a generic side effect, the patient completely misses the mechanical middleman. They don't realize the drug is inducing bruxism, which is causing the pain.
And if they don't know the mechanism, they can't address it.
Right. They might just take ibuprofen, which we know can cause a rebound headache, and now they're trapped in a compounding cycle.
Exactly. If they understand the mechanism, they can take targeted action. They can have a conversation with their prescribing physician about perhaps adjusting the dosage, switching to a different class of antidepressant like an SNRI, or even just getting a custom-fitted dental guard.
Just to protect the teeth and cushion the joint while they acclimatize to the medication.
Education allows for intervention. That's the key takeaway.
Let's look at another chemical that drastically alters our morning reality: alcohol.
The classic hangover.
Right? We are all familiar with the concept of a hangover, but the medical reasoning behind why the hangover headache specifically occurs is, honestly, a masterclass in overnight physiological disruption. How does a drink at 8 p.m. turn into a pounding skull at 8 a.m.?
Well, alcohol inflicts a multi-pronged assault on the body's homeostasis, but the primary driver of the headache is profound systemic dehydration.
Because alcohol makes you pee more, right?
In simple terms, yes. Alcohol is a potent diuretic. It actively inhibits the pituitary gland from releasing vasopressin, which is an antidiuretic hormone.
What does vasopressin normally do?
Its job is to tell the kidneys to reabsorb water back into the bloodstream. When alcohol suppresses vasopressin, the kidneys stop reabsorbing and start flushing. They send water straight to the bladder.
Which explains the endless trips to the bathroom during a night out. You're literally flushing your body's water reserves down the drain.
You are, and as you lose fluid rapidly, your overall blood volume actually decreases. The cardiovascular system has less fluid to pump.
Oh, so your blood pressure drops.
In response to this volume drop, the blood vessels in your brain can narrow to maintain pressure. But more dramatically, as the body becomes desperately dehydrated, the brain tissue itself, which is mostly water, can actually lose volume and physically shrink.
Wait, really? Just visualizing the brain shrinking inside the skull makes my own head hurt?
It's intense. As the brain tissue loses water and slightly retracts, it pulls on the meninges, those sensitive membranes anchoring the brain to the skull that we talked about earlier.
We mentioned the meninges stretching during sleep apnea. Here, they are being physically pulled by a shrinking organ.
Yes. This triggers intense pain receptors. But dehydration is only Act 1 of a hangover. Act 2 involves the liver.
Right, the liver has to process the alcohol.
As the liver breaks down ethanol, it converts it into a highly toxic intermediary compound called acetaldehyde.
Acetaldehyde, is that what causes the nausea?
It causes a lot of things. Acetaldehyde is actually more toxic than the alcohol itself. Before it can be broken down further into harmless acetate, it circulates in the blood, causing widespread cellular inflammation.
So your whole body is inflamed.
Yes, inflammation, oxidative stress, and it contributes significantly to the throbbing nature of the headache.
Now let's overlay medication safety onto this. What happens when you combine this dehydration and acetaldehyde toxicity with a daily prescription?
It creates an exponential stressor. Many common medications, from daily blood pressure drugs to over-the-counter antihistamines, are either diuretics themselves, which compounds the fluid loss, or they require the exact same liver enzymes to be metabolized as the alcohol.
So there's a traffic jam in the liver.
Exactly. If the liver is busy fighting off the acetaldehyde toxicity, it cannot efficiently process the medication. The medication can build up to toxic levels in the bloodstream.
Or its metabolic byproducts can interact dangerously with the alcohol.
Right, virtually guaranteeing a severe chemically induced morning headache. It's a perfect storm of hepatic stress.
Speaking of blood pressure, the independent reports from iMedix heavily focus on the cardiovascular system's rhythms. Blood pressure isn't static, it moves in waves, doesn't it?
It does. It has a very distinct circadian rhythm.
How do those waves crash in the morning, and how do medications mistime the tide?
We have to look at what is known clinically as the morning surge. As you transition from deep sleep to the lighter stages of sleep in preparation for waking, your body initiates a biological sequence to get you ready for the physical demands of being upright and active.
Like getting out of bed and walking around.
Right. It releases a flood of catecholamine stress hormones like adrenaline and noradrenaline alongside cortisol. This surge naturally raises your heart rate and your blood pressure.
It's the body's internal engine revving up before you put it in drive.
Exactly. For a healthy individual, this surge is totally normal and well tolerated. However, for an individual with underlying hypertension or high blood pressure, this morning surge can be dangerously exaggerated.
So the blood pressure spikes way too high.
The blood pressure spikes significantly higher than it should, and the sheer mechanical force of that high-pressure blood rushing through the cerebral arteries causes a throbbing, pulsatile morning headache.
Let's create a hypothetical patient to map this out because I think this is super important. Let's say David takes a standard blood pressure medication. He takes his pill every morning at 8 a.m. with his breakfast.
Okay, a very common routine.
She checks his blood pressure at noon, and it looks fantastic. He assumes he is completely protected. Where is the flaw in that routine?
The flaw lies in the pharmacokinetic trajectory of the drug specifically, its half-life.
What does that mean in this context?
Well, if David is taking a short-acting or even a standard-release antihypertensive, the active concentration of that drug peaks during the day when he took it. But by 4 a.m. or 5 a.m. the following morning, nearly 24 hours after his last dose, the medication has reached the very end of its metabolic life cycle.
So it is essentially worn off.
Yes, the medication leaves the system at the exact moment the body naturally releases the massive adrenaline surge to wake him up.
Oh, wow. So the shield is completely gone right as the attack hits.
Precisely. David is entirely unprotected during the most hemodynamically vulnerable time of his circadian cycle.
And so what happens?
The blood pressure violently spikes, he wakes up with a terrible headache, he takes his new dose at 8 a.m., the pressure drops, the headache fades, and he goes about his day thinking his condition is stable.
He is entirely missing the fact that his medication timing, not the drug itself, but the timing, is leaving him exposed to a dangerous morning spike that could precipitate a cardiovascular event like a stroke.
Exactly. And this perfectly highlights why platforms like iMedix emphasize the details. It's not just take a pill for blood pressure, it's understanding the 24-hour cycle of that pill.
We've covered a massive array of mechanisms so far. The rebound of upregulated pain receptors, the vasodilation of adenosine hitting unblocked receptors, the hypoxic stress of sleep apnea paralyzing the airway, the neurochemical shift causing jaw clenching, the dehydrating shrinkage from alcohol, and the unprotected cardiovascular morning surge.
It is a lot of ways for the body to go wrong.
It really is.
Yeah.
But what about migraines? Because a migraine isn't just a headache, and they notoriously seem to strike right at dawn.
Migraines are in a category of their own. They are complex, systemic neurological events. They involve waves of altered electrical activity traversing the brain, known as cortical spreading depression.
Cortical spreading depression, that sounds intense.
It is, and it's coupled with severe inflammation of the blood vessels and surrounding nerves. And you are absolutely correct. Statistical data shows a massive cluster of migraine attacks initiating in the early morning hours, typically between 4 a.m. and 9 a.m.
Why is that specific window such a danger zone for a migraine brain?
It comes back to the immense biological transition we discussed earlier. The migraine brain is hypersensitive to change. It craves absolute routine.
So it hates the waking up process.
The early morning window is a time of rapid physiological shifting. Cortisol levels are skyrocketing to wake you up. Melatonin, the sleep hormone, is plummeting. Your core body temperature is shifting. Serotonin levels are fluctuating as sleep architecture changes.
That's a lot of variables changing all at once.
Right. For someone prone to migraines, these rapid overlapping shifts in homeostasis can serve as the ultimate internal trigger.
And how do preventative migraine medications factor into this morning vulnerability?
Similar to the blood pressure scenario with our hypothetical patient, David, if a patient is taking daily preventative medications, the trough level, which is the absolute lowest concentration of the drug in their bloodstream, often occurs in the early morning hours before their next dose.
So just as the circadian triggers are firing on all cylinders, the neurological chemical defense is at its absolute weakest point.
Exactly. It's a window of extreme vulnerability.
So if the slow burn, everyday morning headache is often mechanical, like jaw clenching, or chemical, like a drug wearing off, there must be a completely different profile for the dangerous, life-threatening headaches.
There absolutely is.
Because a ruptured blood vessel wouldn't just feel like a bad hangover. We have to establish the guardrails here. How do we differentiate between a headache that means you need to adjust your medication timing and a headache that means you need to call an ambulance?
That differentiation is the absolute core of practical patient safety. We have to delineate the benign from the emergent. We look for clinical red flags, which are features that deviate drastically from the metabolic and mechanical patterns we just explored.
Okay, what is the most urgent red flag to look out for?
The most urgent red flag is what neurologists call a thunderclap headache.
Which sounds exactly like what it is, I imagine, a sudden explosive onset.
Yes, it is a headache that reaches its maximum severe, agonizing intensity within seconds to a minute. It is often described by patients as being hit in the head with a baseball bat or simply the worst headache of my life.
That sounds terrifying. What does it mean?
This is a medical emergency. It is highly indicative of a subarachnoid hemorrhage, a bleeding in the space surrounding the brain, often from a ruptured aneurysm.
So you don't wait to see if it passes.
Absolutely not. You seek immediate emergency medical care. Do not wait.
So onset speed and peak intensity are crucial. What else sets the dangerous headaches apart from the chemical ones?
We look closely at systemic and neurologic symptoms. If a morning headache is accompanied by a sudden, unexplained fever, chills, or dramatic weight loss, that suggests a systemic infection or an inflammatory condition, not just a medication side effect.
Right, medications don't typically cause a sudden fever.
But the true line in the sand involves changes in nervous system function.
Meaning the brain is struggling to process basic commands. Things like numbness or slurred speech.
Exactly. If the headache is accompanied by sudden numbness or tingling in the face or extremities, weakness or paralysis on one side of the body, sudden difficulty speaking or understanding language, profound confusion, loss of balance, or sudden changes in vision like double vision or loss of a visual field.
Those are all major warning signs.
Yes, these are signs of acute neurological compromise, potentially a stroke or a transient ischemic attack.
Furthermore, from what I've read in these clinical reports, headaches that change based on your physical position are a massive red flag. Like if a headache wakes you up from a sound sleep and it gets exponentially worse when you cough, sneeze, or strain on the toilet.
That is an excellent deduction. Pain that exacerbates with those specific actions, which are known clinically as Valsalva maneuvers, suggests an issue with increased intracranial pressure.
Because bearing down increases the pressure in your head.
Yes. When you bear down or cough, you naturally increase the pressure inside your skull. If there is already elevated pressure due to a mass, a lesion, or abnormal fluid dynamics, that extra mechanical strain causes severe pain.
And that definitely requires a doctor's visit.
This warrants a comprehensive neurological workup and imaging. And, the goal of detailing these red flags is not to induce hypochondria, but to cultivate informed vigilance. You cannot manage your health if you cannot accurately assess the severity of your symptoms.
Here's where it gets really interesting. We usually think of safety implications in the context of the explicit warnings on a pill bottle. The little graphic of a steering wheel with a red line through it. Do not operate heavy machinery.
Right, the standard warnings.
But what this data reveals is that simply starting your day with a chemically induced morning headache fundamentally alters your baseline safety and well-being before your feet even hit the floor. It's not just a sensation of pain, it's a systemic impairment.
What's fascinating here is how this reframes the morning headache from a mere annoyance into a critical safety signal. A morning headache, particularly one driven by underlying hypoxia from undiagnosed sleep apnea, or a complex drug withdrawal mechanism, carries a significant cognitive toll.
Like brain fog.
Worse than just brain fog. Your executive function is degraded. Your ability to assess risk, process complex information, and react quickly is compromised.
Wow, so driving to work is actually dangerous.
If you wake up with a medication-induced headache and immediately get behind the wheel of a car to commute in heavy traffic, you are operating heavy machinery while neurologically impaired, even if the medication label didn't explicitly forbid it. The headache is the impairment.
And if you just take a painkiller to silence the headache, you are essentially just putting earplugs in so you don't hear the smoke alarm. You aren't putting out the underlying fire.
Precisely. You are silencing the body's warning system while the underlying physiological mismatch continues to wreak havoc. This leads us to a crucial demographic question. Who is actually standing in the most vulnerable part of this landscape?
Because medication-related morning headaches do not strike the population equally.
They don't. They are deeply influenced by specific interactions between an individual's unique biology and their treatment regimen.
Right. The person taking one allergy pill is not in the same risk category as the person managing a complex web of prescriptions. Let's talk about polypharmacy.
Polypharmacy is clinically defined as the concurrent use of multiple medications by a single patient, typically 5 or more.
5 or more daily medications. That's a lot of chemical interactions.
It is, and this is incredibly common, particularly in older adult populations who are managing various overlapping chronic conditions. They might have a statin for cholesterol, a beta blocker for hypertension, an NSAI for arthritis, an SSRI for mood, and a hypnotic for sleep.
The more pills you introduce to the system, the more that toddler-drawn map looks like a tangled ball of yarn. The interactions don't just add up, they multiply exponentially.
The pharmacokinetic complexity becomes staggering. You might have drug A inhibiting the liver enzyme needed to process drug B.
So drug B just sits there.
It causes drug B to build up to toxic levels, extending its half-life and drastically increasing its side effect profile, which might manifest as a severe morning headache. The likelihood of an adverse reaction being the result of an invisible drug interaction skyrockets in polypharmacy scenarios.
And beyond just the number of pills, we have to look at the machinery of processing them, the liver and the kidneys. How does age change the way our bodies handle these chemicals overnight?
Age is a massive, often overlooked variable. As we age, our hepatic, meaning liver, and renal, meaning kidney functions, naturally decline.
They just slow down.
We lose functional mass in these organs, and blood flow to them decreases. This means an older adult metabolizes and excretes drugs much more slowly than a younger adult.
So a standard dose of a medication that clears completely from a 30-year-old system by 6 a.m. might linger in a 75-year-old system until noon.
Exactly. If that 75-year-old takes a sleep aid, the prolonged presence of that drug in their system due to slower clearance causes lingering respiratory depression, morning grogginess, and chemically driven headaches long after they've woken up.
So the exact same pill at the exact same dose presents a completely different safety profile depending solely on the metabolic age of the patient.
That's why personalized medicine is so important.
And it's not just age, it's the genetic lottery of your liver enzymes, right? I was reading about the cytochrome P450 system. Let's demystify that because it sounds incredibly complex, but it's fundamentally about how fast your body's factory runs.
The cytochrome P450 system is a family of enzymes in the liver responsible for metabolizing the vast majority of drugs we consume. Think of it as a massive sorting and processing factory on a conveyor belt.
Okay, a conveyor belt. I can picture that.
But here is the critical variable. Genetic mutations dictate how fast your specific factory runs. Some people are what we call ultra-rapid metabolizers.
Ultra-rapid, meaning their conveyor belt is set to max speed.
Yes. Their liver enzymes process certain drugs so aggressively that a medication meant to last 12 hours is chewed up and eliminated in 6.
Which means they would be highly susceptible to early morning withdrawal headaches because the drug leaves their system prematurely?
Spot on. The drug is gone before the night is even over. Conversely, some people are poor metabolizers.
So their conveyor belt moves incredibly slowly.
If they take a standard daily dose, they cannot clear the previous dose before the next one arrives. The drug accumulates in their system day after day, leading to toxic buildup and severe hangover-like morning headaches.
This is what creates this massive vulnerability gap. A patient takes a medication exactly as prescribed by their doctor. They trust the system. But because of their age, or because they happen to be an ultra-rapid metabolizer, or because of the other 4 pills they take, they wake up in agony.
And the gap is that they have absolutely no idea why.
Right. They think it's a personal failing or just a bad pillow.
Empowering the patient to bridge that gap is the sole purpose of independent medical translation. If you don't know why you are affected, you cannot advocate for your own safety.
You can't just walk into your doctor's office and say, I suspect my SSRI is inducing nocturnal bruxism, resulting in these bilateral temporal headaches. Can we discuss adjusting the dosage or exploring an alternative class of medication?
Most people won't say that, no. They just suffer in silence.
So what does this all mean? If I'm a patient trying to advocate for myself, and I'm looking at a standard regulatory warning label that simply says may cause headache, how am I supposed to practically compare my situation with alternatives without having a degree in pharmacology? The warnings seem to exist to protect the company, not to educate the patient.
This raises an important question about the fundamental limits of regulatory labels. The FDA and similar regulatory bodies require pharmaceutical companies to aggregate all adverse events reported during clinical trials.
So headache ends up listed on almost every medication because statistically, someone in a 1,000-person trial will get a headache.
But that label is just an aggregation of incidents. It tells you what might happen in a vacuum. It does not provide the phenomenology or the comparative context needed to make a medical decision.
It's like a weather forecast that just says weather will occur today. It doesn't tell you if it's a gentle breeze or a hurricane, and it certainly doesn't tell you to bring an umbrella.
That is a perfect analogy. The regulatory framework is optimized for broad legal transparency, not for individual actionable education. This is where the art of comparison becomes vital.
So how do you compare them?
If a patient is taking a specific beta blocker and experiencing severe morning surges and headaches because it's wearing off too early, reading two different package inserts won't help them. The jargon is just too dense.
Right, they need an independent platform that synthesizes the pharmacokinetics.
Yes. A platform that can tell them, drug A in this class has a half-life of 6 hours and frequently causes morning withdrawal symptoms in rapid metabolizers. Drug B in the exact same class has a half-life of 18 hours and provides a smoother pharmacokinetic taper, drastically reducing morning headaches.
That is the translation from raw data to actionable insight. It transitions the patient from being a passive recipient of a frustrating side effect to an informed, active participant in optimizing their own treatment plan. It takes the murky, confusing waters of a morning headache and provides a high-definition filter.
It's so empowering when patients finally see the connections.
We have covered an immense amount of ground today, peeling back the layers of a symptom that millions of people write off every single morning. We started by understanding the critical need for independent translation of medical data, avoiding the toddler-drawn maps of the internet. We took a deep physiological dive into the nighttime body, exploring how medications interact with our neurochemistry, our sleep architecture, and our liver enzymes.
We examined the counterintuitive mechanisms of rebound headaches from painkiller overuse, the aggressive vasodilation caused by caffeine withdrawal, and the terrifying hypoxic stress of sleep apnea and how sedatives exacerbate it.
We looked at the neurochemical shifts of SSRIs forcing the jaw to clench, the profound dehydrating and toxic effects of alcohol metabolism, and the precise timing failures of blood pressure medications, leaving the body exposed to the morning catecholamine surge.
We also established the vital guardrails, delineating the slow burn, chemically driven headaches from the explosive red flag thunderclap headaches, or those accompanied by neurological deficits that demand immediate emergency intervention. And we tied it all back to the reality that a morning headache fundamentally alters your baseline safety.
Exactly. My final thought for everyone listening is simply a reminder that knowledge is only power when it is applied.
We have explored complex pharmacology and physiology today, but the ultimate goal is to use this understanding to improve your daily health span. I encourage you to challenge your assumptions. If you are waking up in pain, do not simply dismiss it as a bad night's sleep or a stressful week. Look objectively at the medications you are taking, consider the timing of those medications, evaluate your sleep quality, and utilize independent, evidence-based resources to map out your own biology. Be rigorously curious about the mechanics of your own body.
I couldn't agree more. Be curious about your biology, because it is the only house you get to live in. As we wrap up this deep dive, I want to leave you with one final, lingering thought based on everything we've unpacked. Think back to our opening discussion about the X-ray. We desperately want our health to be obvious, visible, and easily categorized. But the human body is a master of subtlety. It communicates in complex whispers, a tightened jaw, a dry mouth, a throbbing temple at 6 a.m., long before it resorts to shouting.
It's true. We have to learn to listen to the whispers.
So, if we can so easily misunderstand the deeply complex risks of the medications designed to heal us, if we spend years blaming our mattress when the actual culprit is an unseen pharmacokinetic collision happening in our liver, what other subtle, everyday signals is your body sending about your routines, your diet, or your treatments that you've simply learned to ignore as normal? Thank you for joining us on this deep dive. Keep asking questions, keep seeking independent answers, and we'll see you next time.